Got started. Can you all hear me?
Yes, sir. We can hear you.
All right. So I'm going to talk about pediatric interventional radiology. I'm one of the attendants here at our VIR division. I'm also the program director for our IR-DR residency program. And since 2014, when I joined as faculty, I have been involved in pediatric cases, and that's the reason I was invited to give this talk on PEDS IR. Just to try to give a brief overview of PEDS IR. Nowadays, IR has becoming a very kind of subspecialty field, where we have, for example, interventional radiologists that only do intervention oncology, for example, or interventional radiologists that will only do vascular work as PAD, for example, and that has becoming more and more common in our field, given the amount of knowledge and different procedures that are out there. This is similar to the adult surgery, for example, when you have vascular surgery, oncology surgery, and so forth. And PED surgery, for example, is something that you don't have that subspecialties. So a PED surgeon will do pretty much all types of surgeries involved in kids, for example, removing liver mass or lung lesions, and similar to that, PEDS IR it's kind of, you need to get involved in pretty much all the areas in IR whenever dealing with pediatric population. And it's a field that is growing more and more, and I can see that in the future it's going to be even more common to have pediatric radiology, interventional radiologists in most of our hospitals, and trying to take care of most of our pediatric patients. So moving forward, IR overall, one of the nice things we do in IR that we do so many different procedures. Last time I checked, there were over 50 different types of procedures that us as interventional radiologists could perform in a patient. That include biopsies, drainage lines, venograms, arteriograms, embolizations, angioplasty, stent placement, ablations, foreign body removal. So it's a very long list of procedures that we do regular in adults patients. And all those procedures can also be performed in kids. So doesn't matter which one of them, but I can tell you that I've performed all of those in our pediatric populations here. One important thing that we all should remember is that kids are not just small adults. They are very different things that we should be aware whenever dealing with kids. We may be doing exactly the same procedure that we will be doing in adult, but we need to be aware that there are different things that we need to be conscious about whenever dealing with kids. First of all, is their physiology. Kids have a different physiology than adults. So, for example, if you see a patient like this one with the following vital signs, with a respiratory rate of 30, a heart rate of 160, and a blood pressure of 185/50. So, depending on how old the patient is, this can be pretty normal or can be somebody that is about to die. If it's an adult patient, this patient is about to die. It's about to call. You need to call the call team because the patient is going to go downhill. If it's a 6-month-old kid, this is totally normal. So you need to be aware of those differences so you know how to deal with those situations. So in a 6-month-old kid, those vitals are pretty much normal. Right? Other thing that I found that is very, very different from dealing with adults is the type of expectations you need to have whenever treating kids. For example, in adult II, pediatric regular II procedure, we do a lot of patients that are in their their final months or final days of life. We do a lot of cancer patients, and they're older patients most of the times that don't have many other options in terms of treatment, and they come to us just for palliation. So whenever dealing and talking to a patient to consent about a palliative procedure, talking to a family member from a patient that is going to hospice, is one type of conversation and one type of expectations you need to set, which is very different, for example, for whenever you're treating a young, cute baby like that one in the picture that has a normal, pretty much normal life and has just a small benign lesion in the arm, which most likely is going to go away with no treatment or kind of very non-invasive options of treatment for a venous malformation, for example, as this kid has. So nobody's expecting this kid to die or to have any complication. We're all expecting the kid to have a normal life and grow and gets better without any issues. So the expectations are really different, and you need to make sure that the family understands that, and that you understand the family expectations, so you don't have issues in the future, and there's no frustration between between you and the families. Right. So be aware that dealing with kids, the expectations are very, very different. And also the disease process are very different as well. So dealing with adults, we have a lot of acquired disease in different from kids that we have a lot of congenital disease. For example, the type of cancers are very different whenever we're dealing with pediatrics and adults. So you need to be aware of those differences and be familiar with those in order to be able to treat them correctly. Right? So talking about disease processes, let's take a look at this very common problem in our population, hypertension. So the CT here on the left-hand side of the screen is the CT of a adult patient over 60 years old with all the very common disease that we see every day: hypertension, hypercholesterol, diabetes. So the CT shows that the patient has atherosclerotic disease, which is those calcifications in the arteries, mainly in the renal arteries. So this is a very common cause of hypertension in those population, right? In our adult population, due to hypercholesterol, diabetes, atherosclerosis, and then patients will end up having hypertension, and then hypertension will contribute to the atherosclerosis, and that's a kind of vicious cycle. So on the right-hand side, we have a CT of a 6-year-old kid that also has hypertension. And as you can see in the aorta and the vessels, there's no calcifications. There's on the bottom picture, we have the kind of the ostium of the right renal artery, which is pretty clear. There's no calcification whatsoever, but still the patient has hypertension. So as you can realize, the disease process is completely different from those two patients. One adult, one is a pediatric patient. So, and that's how you, in those situations, you treat hypertension in those kids. That kid has what we call fibromuscular dysplasia, which is a common cause of hypertension in peds population. And it's caused by some focal disease in the renal arteries or kind of the distal branches of the renal artery. So one way to treat that is doing balloon angioplasty, which is completely different from the way we treat hypertension in adults. The adult population in the past, we thought that doing angioplasty and stent of the renal arteries were a good way to treat hypertension, but it turned out that it's not. So we don't do that for adults, but we do for kids. And that's what we did here in this case. So we did this is a formal aortogram of on that kid. So we have a renal common femoral, right common femoral access. We got a catheter all the way up in the aorta. We shoot the contrast dye and we see the opacification of the arteries. And then we can go more selective and specifically on this is the left kidney. We have the left renal artery. We can see up kind of a small branch of the renal artery. There is a tight stenosis and a post-stenotic dilation. I'm not sure you guys can see my cursor, but this is the second branch of the renal artery. There's a stenosis there. So that area was the culprit lesion for the hypertension on the kid. So we're able to get a small wire across that segment, and we did a balloon, and you can see the wire here on the left-hand side of the screen. And on the right-hand side of the screen, we have the balloon inflated, and in order to open up that narrowing. And that's the result after the procedure. You can see that the narrowing is gone. There's no signs of stenosis anymore. And we kept the patient in the hospital overnight and make sure that the blood pressure was stable before we discharged him. A week later, he went to his nephrologist to check the meds and blood pressure, and the blood pressure was pretty much normal. He was off his medical hypertensive medication, and blood pressure was pretty normal. And he was very, very happy with the results, especially the parents were very happy with the results. And talked to the parents on our follow-up visit. They mentioned that one of the nice things that happened was that he was finally able to enjoy a birthday party and have pizza with his friends, because since he was 4 years old, he couldn't eat any of those treats because of the hypertension. Was in a very restrict diet, so he couldn't eat pizza at all, and he was very happy that he could at that time enjoy the party with his friends. So it was a very rewarding procedure. So, but as you saw, the disease process in adults and in pediatric population are completely different. The way you treat those are completely different, and you need to be aware of that. I'm going to go over some cases, some different procedures that we commonly do in pediatric populations, so you can become more familiar with those. So this is an example of a vascular malformation. This patient was 5 years old and presented with a soft tissue mass on the right groin. And this is the MRI that was done. Usually those patients, they start to have a ultrasound as initial study, and then depending on the results, we ask for a MRI to get a more definitive diagnosis and planning for the procedure. So this is the MRI of the hip. We see here on the right hand side of the screen, we see a fluid collection in the groin. The left hand side picture is the post contrast MRI, and we see no contrast enhancement whatsoever, confirming this is a lymphatic malformation. Okay. We have other similar lesions in the distal, in the mid thigh, with similar characteristics. Again, confirm this was a lymphatic malformation. So one way we can treat this is to do sclerotherapy, which is a procedure where we stick a small needle inside those malformations. We aspirate the fluid, and then we inject the sclerosing agent back into the malformation. And over time, that sclerosing agent will kind of burn and scar down those abnormal vessels and have some symptomatic relief and decreased size of the lesions. So we do that under ultrasound guidance and fluoroscopy guidance, and that's what we did in that patient. The sclerosing agent for this particular lesion was doxycycline. So, and this is the results pre and post the procedure. So we can see, especially in the groin area, the lesion is way smaller than used to be. There's still some residual lesion on the mid thigh, but most important, the patient was completely asymptomatic. Had no complaints anymore. He couldn't feel those bumps anymore in the groin, and was very happy with the results. Right. Another patient, this was a 3-year-old patient with history of trisomy of the 18 and had increased ammonia levels based on lab work. And every time we have a patient with increased ammonia levels, we always think about some issues with the liver, that the liver is not clearing up that ammonia, either because it's not working or because there was a bypass of blood leading the blood flow from the guts straight into the right atrium without passing through the liver. So we, as a usual workup, those patients get a ultrasound and a cross-sectional image to confirm the presence of the abnormality. In this case, the patient had what we call portal systemic shunt or congenital portal systemic shunt. So the patient was born with abnormal connection between the portal system and the systemic circulation. So this is the portal vein, and then we see a catheter coming all the way from the right IJ down to the heart and get into the hepatic vein, the left hepatic vein, and then into the portal vein. So this connection should not exist. So the portal vein should dump into the liver, and from the liver in small portal vein canals, they get to the venulas and then to the hepatic veins and then right atrium. So you should never have a direct connection between the portal system and the right atrium, which we can see in this case. So most of the blood from the guts were being shunted away from the liver into the right atrium and then into the systemic circulation, causing the increased ammonia levels and all the problems that can cause, including encephalopathy, pulmonary hypertension, and impaired developmental delay. So we need to close that somehow. So the way we can do that is to use a plug. We first need to measure some pressures, making sure that closing the shunt would not cause any portal hypertension. And then after that, we can put a plug to block that flow and prevent that shunt to go straight on the heart, the right atrium. And that's what we did there. So we can see that radiopaque plug that over time will close down the vessel. And that's what this is an X-ray of the patient a few months later. That after follow-up, he got an initial Doppler showing that there was no more connection of the systemic, the portal system to the systemic circulation. The ammonia levels were back to normal. And we got this X-ray to make sure that the plug was in the right spot and hadn't migrated to a different location. So this is something that you won't find in an adult population. You can find acquired portal systemic shunts, especially in patients with cirrhosis and portal hypertension. But a congenital portal systemic shunt that we have this kind of big vessel connecting one system to the other one, you don't see those in adults. So another patient, a 12-year-old patient that had a liver transplant 6 months ago and start to have some increased size of the spleen on the physical examination. So that leads to a concerning problem, that is portal hypertension and portal stenosis at the anastomotic site. Remember, every time you tie a vessel to another one, there's a lot of inflammation and scar tissue formation on that site, and those vessels are prone to stenosis and what calls anastomotic stenosis. And this is what happened on this patient. So this is the ultrasound Doppler of the portal vein, and we can see a narrowing of the portal vein at the anastomotic site. We have a turbulent flow. We can see that waveform all kind of all over the place, and a very increased velocity at that spot, almost 300 centimeters per second, which is really, really high. So that is very suspicious for anastomotic stenosis. And in terms of, and you combine that with the clinic findings of increased size of the spleen, you have the diagnosis of portal hypertension due to anastomotic stenosis. So the way to treat this, you can, if you would bring the patient to the OR again and open that up, is really hard, if not impossible, to treat. So one way we can do that is doing a portogram, transhepatic portovenous access, portogram, and angioplasty, and sometimes stent placement. So we got a CT to plan for the procedure, and that's a coronal view of the CT. You can see there the arrow marking. That's a pretty tight stenosis, focal stenosis of the portal vein, and a pretty enlarged spleen. The way we can get access is through the liver. You get a small needle and stick the liver in the portal system, trying to find the portal branch, peripheral portal branch under ultrasound guidance. And once you get access there, you can put a wire and a catheter. And this is the initial portogram where we can see that tight stenosis of the portal vein where those surgical clips are. So after that, you can put a balloon. This is a 10 millimeter balloon that we put across the stenosis and inflate it in order to open that up. And this is the results post stenosis. So it's very, the flow is much better. We don't see collateral circulations. We always measure pressures across before and after the procedure to make sure that we have a hemodynamic assessment of the stenosis, and the pressure gradient was pretty much normal at the end of the plasty. So this is to show the before and after. So very nice improvement of the caliber with decreased pressure gradient. So those patients, they stay in the hospital overnight, just make sure there's not a bleeding complication, because whenever you stick the liver, there's a small chance of bleeding and perihepatic hematoma. So you want to make sure that this is not the case. And if that happens, the patient's in the hospital and ready to go and be treated as needed. So 13-year-old patient, history of metastatic Wilms tumor to the liver. Right? So this is a patient had a big tumor in the left hepatic lobe. This is an MRI. Sorry, cannot show the cursor, but that's the lesion center in the right hepatic lobe, and there's other small tiny spots in the right hepatic lobe as well.
Dr. Yamada, we can see your cursor, by the way.
Oh, you can see?
Yeah.
Awesome. All right. So this is where the lesion is, the bigger one on the left hepatic lobe. There's other tiny little spots here on the right side. Also confirming the presence of right side hepatic lesions. So this patient had all lines of chemotherapy and none of those worked. So the patient was sent to us for what we call radial embolization, which is a procedure that we infuse a bunch of tiny little beads to the vessels feeding the tumor, and those beads are loaded with radiation. So those beads that get stuck in the lesion, and over time the radiation will kill the tumoral cells. So here we have a catheter coming from the right femoral artery. We get a catheter all the way up into the aorta and in the celiac trunk. Then here we have the splenic artery and the hepatic artery, have the right and left and right hepatic arteries, and we are able to do more selective angiograms in order to define where the tumor is or which vessels are feeding the tumor. For this particular tumor, we need to do a SPECT CT, where we inject a technetium-99 inside the vessels to confirm that this is where which vessels are feeding the tumor. And then the patient goes to the SPECT CT and confirm that the tumor is lighting up with the technetium. We can see here on the right-hand side, the kind of pretty bright lesion. And then on the other two small spots, we have a little more activity there as well, showing that those lesions were hypervascular and that we were injecting the right spot. After that, we bring the patient back a couple of weeks later after calculating the radiation dose, and we repeat the same steps of the procedure. We get access in the common femoral artery, put a catheter in the celiac trunk and a microcatheter distal in the hepatic arteries, and then we can infuse the radioactive beads. So this is the way it works. Those beads, they come in the leaded shield vial like this to protect against radiation from whoever is manipulating those vials. And then this is just a drawing to show basically what happens. Those beads, they go into those vascular tumors, get stuck in those vessels, and over time the radiation will act and kill the tumor cells. It may take a while, usually 3 months at least to get the final tumor response, but it can be very, very effective. So those are the cases that I'd like to show you guys. And to conclude, I will just remind that any adult IR procedure can be done in pediatric populations. As I mentioned before, over those 50 procedures that I showed, at least at the beginning, I pretty much have performed all of those in our pediatric patients here at MUSC. You always need to remember that kids are not small adults. Be aware of the differences in physiology, different disease process, and very important difference in the way you talk to the family, and all the expectations are the way the expectations are set between you and the parents and you and the patients, right? Peds IR is a very, very young specialty. There's a lot to grow. One area that has a very, very large potential is the pediatric oncology. This is one of the major areas in an adult IR, but in the pediatric population is very, very not well developed yet. We're still trying to prove that those IR techniques are effective to treat patients in the pediatric age, but that will take a while. That will take more years. But the more we offer those procedures, the more we offer our help, the more familiar the referring physicians will be and more willing they will be to refer the patients to us. So that's what I had to say. It was nice to talk to you guys again. I know that I gave this talk in our VIR symposium, but I'm happy to answer any questions and discuss anything further if you guys want.
Yeah, I have a question for you, Dr. Yamada. So with the patient with the Wilms tumor, it seemed like, he kind of had like a primary mass almost, but like mets kind of all over the place. And I feel like I remember Dr. Johnson saying kind of like, if you have kind of like the cutoff of like whenever you want to embolize these patients, is that like there's no response, it seems like, if patients have masses that are in segments that are non-adjacent to one another, if I remember correctly. He says that like that tends to be a contraindication. Like for Wilms tumor, obviously it's a completely different pathology. Like, is there a contraindication for like where it is in the liver if it's non-adjacent to like which procedure you would use for that? Like, what drove you to decide like tear versus like TACE, and like was it based on location of the lesions?
Yeah, it's for Wilms tumor, and in this population, there's no guideline for which type of treatment you could offer. Right, this is kind of the last resource for this patient. He had to fail all the lines of chemotherapy and options. But whenever we think about liver direct therapy, we always think about lesion size, locations, and the baseline liver function. If the baseline liver function is okay, and which this case it was, you can treat the entire liver with radiation therapy or radioembolization, and you don't have, or you have a very little chance of liver dysfunction. In terms of, because the lesion involves pretty much the entire liver, that's what you need to do. You need to do a whole liver treatment, regardless if you're doing chemoembolization, radioembolization. There's not a good answer for any of those. I'm sure all the institutions will treat those patients with chemoembolization. We decided on radioembolization based on the fact that we know that it works better for metastatic disease. Chemoembolization is well established and well developed for HCC only, or primarily, but radioembolization has been a useful way to treat metastatic disease in the liver, and I think we thought it was a good option for this patient.
And then I think I kind of, at the symposium, I kind of talked to you a little bit about this, but kind of the gamut of instruments that you use for pediatric IR. And, you know, we talked about how there's a kind of a decreased selection, obviously, for pediatrics. And if there's enough incentive to get some of the device companies to invest in making pediatric IR instruments, but like whenever you approach like a pediatric patient, like are you using only things that are licensed, or not licensed, but I guess what I'm trying to think of the word escapes my mind, but like are you using only things that are like developed for pediatric IR patients? Or are you using also like instruments that are for adults, and then that you are like customizing them to fit inside of a pediatric patient? Like,
yeah, we're always being very creative and being flexible. We just use whatever we have in the adults to be using peds. Usually try to get smaller devices. We have, for example, a regular diagnostic catheter in adults is a 5 French catheter, but in pediatric we can use a smaller one, a 4 French, and sometimes even smaller 3 French catheter. We use smaller sheath sizes, smaller needle sizes, but we don't have anything, very little things that are specific for kids. So we need to adapt from the adult inventory and get the smaller devices we have developed for adults and use in pediatric patients.
And this is more of a question which you might or might not be able to answer. I don't know if you have any friends out in the private practice world of IR or not, but like, what's the status of pediatric IR out in like outside of an academic institution? Because obviously here we got Sean Jenkins, and you know it's a very well-known like children's hospital, but it's an academic setting. Like, what does pediatric IR look like out in the community?
Yeah, it's very, very little developed. There's no much private practice there doing peds IR. They're mostly in academic center, in the bigger ones. So it's another area to be developed, to be explored.
And then my final question, just so we can get it on record for a lot of the people who are interested in IR as a career. What kind of is because obviously I know Ed, which is one of the graduating fellows, he's going to do a pediatric fellowship, but what's kind of the track if someone is interested in doing pediatric IR? Like, what do they got to go through to get there?
Yeah, it's a good question. Yeah, so usually we'll go to there are 2 ways you can go to do your IR, DR residency. and then do a fellowship in pediatric interventional radiology, or you can do a diagnostic radiology residency and then go for a pediatric IR fellowship. Most of those places will require you to do a 1 year of pediatric diagnostic radiology first, and then do the second year on pediatric IR. But you can do that either doing a diagnostic radiology residency or a IR radiology or IR DR residency.
And then final question for me, just because I'm curious about this. What is what does clinic follow-up look like for a lot of these pediatric patients? Are they coming to you? Are they following up with their pediatrician mostly? Like what does it look like after you do a pediatric operation?
Yeah, they follow up with me and the referring physicians as well. So IR has become a very clinical oriented specialty for all those complex cases. We see those patients before and after the procedure in clinic, and we have a longitudinal follow-up with them. So for example, those patients with cancer, for example, we see them 1 month after the procedure, usually with a cross-sectional image to make sure that we achieve the response that we needed. Similar to those patients with vascular anomaly, for example, I see them a month after the procedure in clinic, and then decide if they need more procedures or if they're symptomatic, they're okay, and there's no need for additional intervention at that time. But we do see them before and after the procedure in clinic.
I don't have any more questions for you. Luke or Ben, y'all got any questions for Dr. Yamada?
Yeah, I did have one quick one. Could Dr. Yamada, would you mind going back to that first case and just kind of walking through how you determined that it was a lymphatic malformation?
All right. So for those patients that come with the suspicious for venous or vascular malformation, the history is pretty history of physical examination pretty kind of typical. So if you do a nice HMP, you can pretty much get to diagnosis without any imaging modality, just by the way the lesion was presented and the way it's developed and the type of symptoms the patient has. So you can tell what type of disease the patient has, what type of lesion the patient has. So the reason to get any imaging is to, most of the time, is to, if you're in doubt, you can confirm the diagnosis. And most important is to plan for the procedure and check what needs to be done, or what you need to be aware before you treat the lesion. So this patient had a lymphatic malformation, and we kind of knew sometimes the lymphatic malformation can be a little bit tricky to differentiate between venous malformation, but it was a classic finding of a soft mass without much skin discoloration that was compressible, non-pulsatile. It was not warm to touch, and just a little bit tender, that was getting bigger, especially when the patient had some sort of cold or infectious process going on. This was typical of a lymphatic malformation. So we knew up front that that was the case. And then we got the MRI to confirm the extension of the lesion, how deep the lesion goes, how deep the lesion, or if there's any involvement of deeper structures such as muscles, bones, and inside the pelvis. And that's the main reason to get the MRI. So this sequence here that I'm showing is the T2 sequence that has whatever is has water on it. It lights up like this. It becomes very bright. So we have urine in the bladder, and the lesion is pretty bright. That means that there's a very high water content of the lesion. And then to confirm that this is a cystic lesion, we need to get the contrast. So, and this is the T1 post-contrast data, we don't see any contrast enhancement. If there's contrast enhancement, we see a bright spot. So this is the contrast inside the bladder being eliminated by the kidney. So we see that is bright inside the bladder because the contrast is there as expecting, but we don't see any contrast in the lesion. So they're confirming that this is a cystic lesion. If this was a venous malformation, not a lymphatic malformation, you would see contrast in here. So we confirm the diagnosis of lymphatic malformation, and most important, we define how extensive the malformation is. We exclude the fact that it was not going to the muscles or into the joint space or anything else deeper in the pelvis.
Got it. Thank you.
And I guess the question that I had, Dr. Yamada, was just about the future of pediatric IR. So I guess what areas of like pediatric care do you see IR expanding into in the future, or like what specific types of procedures or pathologies do you think pediatric IR is going to take over in the future?
Yeah, I think there's a big role for peds IR in the oncology specialty. I think more and more, as we have seen in adults, IR is becoming one of the biggest or most very important pillar in the management of oncology patients, either doing biopsies, putting lines for chemotherapy, or doing procedures to treat the cancer. This is a well-established in adult population right now, and it's going to be in the future for pediatric population. I think we're still in the early era of peds oncology, peds IR oncology, but I'm sure in the next few years this is going to grow more and more, and IR will be a very important area in treating oncology patients in the pediatric population.
All right. Well, thank you so much, Dr. Yamada. I thought this was a really cool lecture. Definitely some really cool cases in there. We really appreciate you coming today to give this lecture.
All right, guys. Was nice talking to you. Let me know if any help. Always happy to help out, and let anybody know that if they want to shadow us, please contact me or either Dr. Gerzami or Lori Utz. We can take a look at our schedule and have everybody shadowing us whenever they need.
Awesome. Thank you so much.
All right, guys. Have a nice day.
Thanks, Dr. Yamada.
Bye.
Thank you.